So I'm just going to say a few words about transitions in general to set the stage, and then Dr. Cohen will follow with her presentation, and I'll wrap it up. Transitions is an issue that the medical team should be involved in and aware of, even for youth who do not have special health care needs. It's a difficult time of life, and it needs to be incorporated into the medical care of every youth. However, it's much more complicated in youth with chronic medical conditions, youth with special health care needs. There are some misconceptions about transition that we need to make sure that we eliminate from everybody's agenda. The first of these is that transition is a moment of handoff from the pediatric youth provider to the adult care provider. The second is that transitions is an automatic for those of us in family medicine or med peds. I mean, after all, we take care of people the whole lifespan, and so we don't need to think about transitions. And the third is that transition's a unidimensional disease-based process. We're worried about getting them from the medical care for their condition as a youth to their medical care for their condition as an adult. The correct way, in my mind, to debunk these misconceptions is to constantly remind ourselves and everyone else that transition is a process that takes place over time. It's not automatic for family doctors or med peds or anybody else. It requires planning, it requires forethought, and it's an ongoing process, like anything in medicine, of constant reassessment and modification and personalization. And then lastly, transition crosses lots of domains. The medical diagnosis and chronic condition, all the functionality that happens at school, and that's not just education. School plays a huge role in providing mental health services, sometimes general health services, a place to spend your day, socialization, and all that comes to an end when you leave the school system, and we need to think about that. Think about the finances. That changes as you transition from a youth to an adult, both in terms in the healthcare domain, but also your other expenses of transportation, housing, food. Gradually taking autonomy for your medical condition, but also for other aspects of your life. Career and or education changes, and that needs to be managed during transition in the context of the person's whole life, including their medical condition. Sexuality and reproduction is something that sometimes is difficult to talk about, but I'll tell you that's on the top of the list very often for the youth that's transitioning, is what does this mean for me in terms of my family planning ahead, my sex life right now. And lastly, let's not forget about recreation. Recreation changes as you're an adult, and people need that kind of balance in their lives. So having kind of laid out, I think, the issues that are before us when we talk about transitions from a 30,000-foot view, let me turn it over to Dr. Cohen.
I'm pleased to be here to talk with you today about transition. I don't know that any of us have the answers, but I do think we're making strides. And I think in the sickle cell population, many of the things that you just said are so true. This is a life, but then you have to bring along the chronic disease and how it impacts the life. But you can't forget the life. So schooling, goals, future, desires, friendships, all of those things that are so important to teenagers remain so important to our population of patients. No disclosures. So the learning objectives are goals of a transition program for us, unique aspects of transitioning as it impacts sickle cell disease and as sickle cell disease impacts transition, and age-related transition concerns. So it was often age rather than preparedness which dictated when the transfer of medical care would occur. And as you can imagine, leap and the net will appear. The net was often filled with holes, and the fish would fall through, so to speak. So you cannot just leap and think that someone is there to catch you, even if you have an adult program that is amazing on the other end, which many people do not in transfer from pediatric sickle cell disease care. So the goals of a transition program for children with special health care needs, education regarding the disease, I think that is just a general statement that certainly applies to sickle cell disease as well. The more educated you are about your disease, the better decision-making practices you can take part in. Understanding the patient's personal medical history, which is not a general statement for anyone with sickle cell disease or any other disease. Development of a skill set with which to navigate the adult healthcare setting, because it is different in many ways from the pediatric setting. Engaging patients and facilitating conversations that lead to the identification of the needs and then later to readiness for transition. We need to better understand where the patient is, not where they are going. So we have to start with where the person is. And a successful transition cannot be left to chance, and I think that's what we did. We crossed our fingers, we hope for the best. We have a wonderful adult facility, and we thought that was going to be enough, and it's only the beginning. So this is an intentional and active, ongoing process. You cannot focus solely on teaching a patient his or her medical information, though that is an important piece. You have to bring forth and address every patient concern about the process itself for it to be successful. So what does the patient see as the most important step for a safe and smooth transition? Again, it's meeting the patient where they live and not where we are. Can't solve the problem you can't define, that's for certain. And our steps to rectify the problem may not be the patient's steps at all. So then you're on two different pages and they've tuned you out. Unique aspects of our patient population do need to be considered in the design of the program for pediatric patients with sickle cell disease. For example, overt strokes or silent cerebral infarcts affect cognition, and they are present, including the silent cerebral infarcts, in approximately 30% of the population at the time of transition. That's a very, very important number. So our expectations of our patients need to be that they're going to do very well, but also, is there something that might be interfering with that for them? And we'll get to that with our patient presentation. High rate of comorbid diseases, such as asthma, for example, in our patients, and we can't forget about those. Higher proportion of adolescents with sickle cell disease receiving public health insurance when compared with other pediatric genetic or chronic disease populations. So we have got to assist them in understanding what that transition is when they become an adult at 18, even if they stay with us in our clinic for a number of years to follow. So Dr. Lebensberger and team examined barriers to care for sickle cell patients when they transition. And one of the important ones that they noted was only 60% of our pediatric centers are able to refer patients to an adult sickle cell disease hematologist. So where do the other 40% go? So they go somewhere. They may go to an adult generalist, and that's really not enough. And so Kunal mentioned telehealth, and I think there certainly are wonderful avenues for telehealth when you have a patient who doesn't have an adult sickle cell disease practitioner, but has a very invested adult practitioner, so you can make it work, as a team. The transition from pediatrics to adult sickle cell care appears and is a high-risk period for mortality. So that's a pretty important statement right there. Dr. Brousseau et al. Noted an increasing number of acute care encounters, hospitalizations, and deaths regarding the care of patients with sickle cell disease shortly after their transfer to adult care. They use the 18-year-old mark. That is definitely a moving target, thankfully moving towards the older patient rather than younger. So young adults have greater than 2 times the amount of emergency room visits per year than their younger counterparts, and greater than 1 time than their older counterparts, more inpatient stays than either, highest percent of frequent acute care visits and return to acute care within 14 days. And that early hospital readmission in patients with sickle cell disease has been correlated to increased mortality. So why are they coming back? What did or didn't happen in the initial visit? What is it that they didn't receive, or did we miss something? I don't think the answers are out there, but we certainly have to think about readmissions and why the patient is returning. So I saw a petal model, a flower model this morning, and this is our flower model. This is a team effort. It is a comprehensive model taking time and teamwork, and there are a lot of moving parts, including the patient themselves. So physicians need to begin to discuss this process as a concept with your pediatric patients at each visit. And I think physicians make the decision about when to start this process. So we have just learned, probably in the last 3 to 5 years, that frontal lobe development does not finish until 25 years of age. Yet children become adults at 18 and they consent for whatever it is that they need to consent for at 18. But yet that frontal lobe is not fully developed. So we're asking a lot, and especially in a population of patients where 30% may have had silent cerebral infarcts, which may be impacting their cognition. So we need to keep that in mind, but that doesn't mean we don't start talking about it as early as we can. We just may not finish talking about it for 10 years to follow. So we discuss with our subspecialist and our either pediatrician or family medicine doc, when does this need to occur by the rules of the institution? And I think everyone's institution is different, but there are regulations, and that again is a moving target. I think with Obamacare, our target has moved from 21 to possibly 25 years of age for our kids with chronic diseases. So we may have some leeway there. We may have a patient at 18 that's ready to go, and that means they're ready to go. We've talked about everything, we've discussed things, they're on the path, and they're happy to move on to adult care. That's totally okay too, but we want to be careful to not push someone out who's not ready to go when we can help it. So if the pediatrician or family doc and ourselves are talking about this in the same fashion, then we're creating trust with the family. Good communication matters. We can't say one thing and the pediatrician or family doctor says another, or vice versa, because then the family really doesn't know who to believe, and we've already gotten off on the wrong foot. So let us as physicians begin to equip our parents and our patients. How do we do that? We need to talk and observe and discuss and rediscuss our parents in teaching skills that will enable their child to slowly begin to achieve independence, the same way as they would in general, but also with their disease process. So it's harder, right? It's already hard as a teenager. So now it's harder because they have to grow up, and they have to grow up with sickle cell disease. But it's not impossible. And patients, we need to equip them with skills that will allow them to gain confidence in themselves, small steps, and in their decision-making abilities. So we have a transition clinic, Transition Together, and our visits begin at 15 years of age. I would prefer they begin earlier, but it's a staffing support issue, so we begin at 15, but we don't start talking about it at 15. You try to talk about it with a patient that is mature enough to understand what the word means as soon as you think that they're ready and their family is ready. It becomes part of what we do. Twice yearly visits, there's a survey, an online survey, to be completed at each visit, at these twice yearly visits. It can be done from outside the clinic once the patient gets rolling and understands the survey and doesn't have questions about it. It's a longitudinal tool to determine if we can positively impact this process by addressing issues which the patient states he or she needs assistance with in order to achieve that independence. We use a motivational interviewing style of listening without judgment. The patient directs the goals for the successful transition visit and ultimately for a successful transition. So they decide what it is they want to work on, and they decide what it is that they're concerned about at that visit and what they need to really focus on and what they need answers to. We don't do it necessarily in an order of A through Z. So we might jump around a bit because they need to, because their questions are focused on something else, so they don't hear what we say if we don't hear what they say. Goal setting happens at each visit. Readiness assessment at each visit, not that we expect in any way readiness at the age of 15. It contains a portable medical summary embedded within the survey. I think that's very important now that we've moved into the EMR records, because a sickle cell patient can have a very long medical summary, and they may really not know when their last echo was. I don't think it's fair to say you need to really have a handle on each and everything that has happened to you. Certainly, some may, and they take pride in that, and they should, but this helps them with the things they may not necessarily know. There's education at each visit, both medical, which includes a series of short lectures, one building on the next. And then there's education directed at the patient concerns. Teenagers often believe they're invincible, so this isn't so easy. And then there's education directed at the parents' concerns. And there's a fear of the unknown which takes on a life of its own, as you'll see in our case. And so it's difficult to know where to direct that education, but if you don't ask, you won't know, and so you can't try. There's partnerships with our colleagues, both subspecialists and outside of the specialties, such as pharmacy, for example. So here is our patient history. Cece is a 15-year-old female with SS sickle cell disease. So her past medical history importantly includes a history of a stroke at 12 years of age. And she is currently receiving chronic transfusions, which means she gets a transfusion typically every 4 weeks. She has iron overload as a result. She has a history of asthma, which is a risk for sickle cell patients as far as future and lung disease. She has numerous admissions for acute chest syndrome. She has occasional admissions for vaso-occlusive crisis or pain. Her past surgical history includes a tonsillectomy 5 years ago for obstructive sleep apnea, likely related to her sickle cell disease. And then she's on a number of medications: penicillin, folic acid, albuterol, Flovent, a long-acting for asthma, and Exjade, which is for iron overload. She does not have any allergies. Her social history: she lives at home with her mother, aunt, and uncle. She has no siblings. She's in the 10th grade, and she's struggling to do well due to the monthly clinic visits and hospitalizations. Immunizations, up to date, question mark. Not sure that we have talked to the pediatrician about those immunizations. So that's why I put a question mark. So we aren't interfaced with their system necessarily for immunizations in Pennsylvania. And so it's very important to keep very close ties on that with our colleagues, because penicillin requirements have changed. Penicillin itself for an older patient may not be necessary, but boosters to Prevnar 13, et cetera, need to be given before we make that decision. And so it's important we have this information in our chart. And we keep getting updated information and sharing it. So family history. Her father passed away from complications of sickle cell disease when she was 4 years of age. Mother has a history of anemia, hypertension, and depression. The physical, I'm not going to kind of go through each and every piece of this, but I think it's important to know that her GU exam is behind age. So her Tanner stage is 3 to 4, and she's 15 years of age. Her musculoskeletal exam notes a slight decrease in grip strength post-stroke, and that matters for what she writes and how she can function in school, so we need to keep that in mind. Everything else seems to be fairly normal at this visit. So here she is, and here's our transition visit. Medical. She has a lack of menstruation. She has a lack of understanding regarding her disease type, and how do we know that? We've asked. She has a lack of understanding regarding iron overload and why she has that and what we can do about that. Social history-wise, concerns about school performance and a concern regarding her mother's ability to bring her in for these transfusions, as her mother works and might lose her job. So that's something very important to both her medical and her own social development. So from the parent's standpoint, so mom brought her, and she says Cece is having difficulty in school, with schoolwork and with keeping up. She's having difficulty making friends. So again, we need to meet the parent and the patient where they are, both together and individually. So what were the similarities? Both had concerns about school and schoolwork. But the difference is the patient is concerned about her mom and her mom's job, whereas mom is concerned about her daughter's inability to make friends. Neither of those were mentioned by the other party. So we're learning something about the mom from the patient and something about the patient from the mom. The physical assessment noted that puberty and menstruation had not yet occurred. Puberty had occurred, but not fully, and menstruation had not yet occurred. And then the survey does an assessment with the pieces and parts of it, and we go through that at each visit. So we review that together as a team, and then with the patient. And then the educational process begins. So we talk about the disease type. That's very important. You have to have a foundation laid, and that is the foundation of sickle cell disease. You have to know your disease type before you can know what it is you're looking for and why. We talk about iron overload and the fact that the patient is on Exjade for that iron overload. So she's already receiving a medication for iron overload, but is it working? And we talk about puberty in sickle cell disease and how it may be delayed, and thus the reason she hasn't begun menstruation. But we also talk with her about when we're going to address that, when we want to worry about that she can be reassured. We're going to look at her height and her growth and do all of those things because this is something that's bothering her. So we have to let it bother us so we can march forward with the things that she has determined are important to her at this age. Now, much of what you see here is something that her primary care physician is also doing. So they have noticed her GU status and her lack of menstruation. And so again, it's a work together process. When we send a letter, we're going to comment on that, and we may even call her primary care doctor and say, so what are your thoughts about this, and what are you talking with her in regards to this, because she's concerned about this. So at 17 years of age, I've skipped ahead 2 years. They come every 6 months. But we're going to review the most recent visit and the goals that were set. Do they always meet their goals? No. Did Cece meet her goals? No. That's not relevant because all of us have a long list of things that we do, and it keeps shifting, and many of the items fall to the bottom, come back to the top, fall to the bottom. And so just like us, teenagers have to be reminded of their goals, the goals that they wanted to set, the things that were important to them, and give them the next and the next and the next chance. Or say, why is it that you're not meeting this goal that we set together? What is it that's keeping you from achieving that? Medical, difficulty with sleep at this visit, increasing admissions. Social, new boyfriend, we are getting serious, unquote. Her peers are drinking and smoking. They're talking about college in the future. The mom, again, mom is with her. She's not sleeping, she's walking around the house, she's on her phone, she's doing all these teenage things. Therefore, she isn't doing well in school. She has a new boyfriend. I know women who have sickle cell disease that become pregnant and they can die from pregnancy. What am I going to do about that? She wants to go to college. How can I stop her? She can't leave her doctor. She'll never be able to take care of herself. This is the mother's feeling. So this is a true scenario of a patient, and so mom needs us to sit down one-on-one and talk about these fears, because while she's getting some of her facts as truth, she's mixing them together with her daughter and creating a state of hyperdrive fear that is not, it's not helping her daughter and it's not helping her. So we really want to talk with her. And I think it's important in this case to remember that this young lady has had a stroke. So mom needs to be involved. Moms always need to be involved, but mom needs to be involved in bringing up some things that the young lady may forget to bring up. Towards the end of the conversation, mother begins to cry and says, Cece's struggling this summer with more admissions. What is happening to her? Is she getting sicker? Will she be one of the children with this disease who dies young? My husband died at 24 years of age. You know that, right? And I think it's very important that we do know that, right? So you can't forget the family story, because again, that's impacting mom and her ability to move forward with her child's independence. She's an invested mom. She's a lovely mom. So you have divergent needs. You remember that the parent should be a participant in this child's preparedness. She is shifting the balance of the work as the young lady becomes more engaged in the process, but she can't do that if we don't help her because the disease is overwhelming her. Similarities, they're both worried about insomnia and the multiple admissions, which we'll discuss. Differences, the boyfriend in a different light, drugs and peer pressure needs to be discussed with the young lady alone. And then college, future, grades, what are the goals of this patient? And these issues, again, are also discussed with the primary care doctor when they see him or her. So we're still sharing the same information and reinforcing the same things. So just to move forward, because I'm getting some eye. So the educational process continues. So we're going to talk about all these things, and we're going to send a letter to the primary care doctor, and we're going to call if we think there's something that needs addressed by them as well, so that we can, again, all remain on the same page. At the end of the day, the most overwhelming key to a child's success is the positive involvement of parents. So if you have a parent that wants to be involved, let them. There are some parts of the visit where you'll ask them to step out, but you have to be, as a physician, you have got to be cognizant of this young lady's development, despite her stroke, to know when and where that, how that falls into place for her. So briefly, at 19 years of age, again, we review the goals, but now she has some medical complaints, and she has some non-compliance. She's having a difficulty holding her job due to absences, and she needs to talk about disability and where she's going to live. Mom is concerned about her medicines too, and then she starts talking about her forgetfulness. She wants to move out. Mom doesn't know what to do. Now the patient is 19. Should the parents still be involved? And my answer is, as I said, yes, I believe so. If the independence is growing because this young lady has her cognition is normal, then you're going to already have worked over these 4 years to have mom or dad stepping out. Similarities, differences, and then the education. So now we have to think about neuropsychiatric testing in our young lady, if we didn't think about it before, because we're getting a lot of red flags. And that's very important before you send a patient to the adult hematologist to give them a baseline. Where is this patient? There are teenagers with teenage behavior in every family, and then there are patients who aren't able to have the cognition that another patient at her age might have. So you need to tease that out a little bit. So we need to break down the information in a stepwise fashion. Show the child how to contact important resources, such as 911, physician, pharmacy, social work, insurance, transportation, and we do that both in the clinic and we encourage the family to do that at home. We need to help the child become responsible for making and then keeping appointments. So the goals on many of our transition patient discharges are make your appointment, keep your appointment. And lots of times they come back having made the appointment, but they may not have kept the appointment. So we're one step closer, and we just repeat, and they get there. We need to help the child to become responsible for asking for and picking up refills in a timely fashion. To call the pharmacy and say, I need a refill, if there's no refills on the medication, means they're not going to get a refill, so then they need to call us. So we work on that, and again, that's an educational piece. We need to assist the patient with understanding his or her disease so they can begin to develop independence, meet them where they are. Motivational interviewing is open questions, affirmation, reflective listening, and summary of reflections if you haven't heard that before, ORS. Learn what they know, correct and incorrect. We cannot teach if we don't know what the basis is. Independent decision-making must be based on correct information and fact. Teach ways in which to help your child live a healthy and productive life as it relates to the disease. Communicate so that you, as the parent, can stay informed. Be careful not to be overbearing. That's, I don't know, as a parent, a little hard to do for each and every child. But you learn how to step back, and we watch our parents learn how to let their child achieve independence. It doesn't happen automatically, no matter what the books say. Observe their skills as a manager of their disease. Don't leave it to chance. We have the parents bring us back information about that. What is a good decision they made? What is a bad decision they made? Be present and supportive. So if you can't fly, run. If you can't run, walk. If you can't walk, crawl. But by all means, keep moving. Martin Luther King Jr. said that, and I think that's true. This is our initial beginning transition team. It includes a social worker and a nurse practitioner, and a physician. It has grown and will soon include a psychologist, about which we're really excited. And that is their choice. That is not our choice. So if they'd like to see our psychologist, then that's going to be an option, and I think it's a good one for some of our patients. So thank you.
All right, well, thanks. You've left me nothing to talk about. That's great. We can all go home. So I got involved with Medical Home for Children with Special Health Care Needs during a NICHQ Learning Collaborative. That's the National Institute of Child Health Care Quality, about 20 years ago, and that's how I got pulled into this whole world. What I'm going to do is hit what I think are the high points or the key points about a few things. One being what advanced primary care looks like, because I don't think everybody in the room has a sense of that, and primary care can be very varied. Number two, some thoughts on care coordination, and then specifically the transition piece. I have no disclosures. My objectives are that at the end of this, we'll be able to describe the functions of quality primary care, state the components of a basic transition care plan for youth with special health care needs, and appreciate the importance and challenge of care coordination between PCP and subspecialist. This is old. This is an old concept that we primary care physicians kind of measure ourselves against. The 4 C's of high quality primary care: contact, which means accessibility, coordination, comprehensiveness. We're dealing with the whole patient and all their various needs. It doesn't mean we're doing everything for everything, but we're that we can be the starting point and the contact point for it. And continuity. They have same names, faces. It's not big box medicine where you may get a different physician, different care provider. This is my transitions care plan. There are a lot of care plans out there in the literature for transitions for youth with special health care needs. I found most of them way too busy and complicated for my simple mind, and I think this is easier for patients to work with. It certainly works better for me, and I think part of what high quality advanced primary care is you tailor things that have been shown to work to your individual practice and patient culture and situation. I'm just going to go through the first few that kind of go before age 15. And when I first started using this many years ago, we were in a paper chart, and I actually would keep this in the chart and update it every time the patient came in and staple things to it. Now I use it, I still have it in the EMR as a document I can pull up, but now we more pull it up each time and kind of look back and forward a little bit for around that visit and try to make sure we're on track with those tasks, and then keep notes, whether it's on a printed version of this or just in the medical record. So briefly, I have it divided into age and task, when we want it sort of completed, who's responsible, and then a place to keep track of the progress. So in general, 12, many people think is a good time to think about beginning transition. And that, of course, is going to vary by patient, by condition. But I like to bring up that at the 12-year-old visit, I like to bring up the concept that we're going to be starting to think about transition over the next several years. And we don't do much else about that. But just talk about what transition is and some of the things I told you guys about before. 12 to 13, we start to make sure that the patient understands their condition in terms that mean something to them and to their level of ability to comprehend and ask questions. At 13, we start to ask about vocational aptitudes and interests. And try to have some list of those things by the time they start high school. At 14, and that may be too late, begin to have a talk about sexuality and reproductive life and the effects of the special health care need, and just the general stuff that I have to talk about with every adolescent. And under the WHO, you'll see PCP parent, PCP and patient, and parent and child. So these can be, as we discussed before, kind of multiple discussions. And if we get time to go to the case briefly, I'll kind of use this as my guidance as we talk. This is page 2. How do you best integrate transitions into the ongoing care of the patient? And that should be individualized. There are certainly advantages to incorporating transitions and their chronic condition management issues with the usual adolescent's wellness and prevention care, because a lot of the topics overlap and are just expanded when it comes to the special health care need. On the other hand, that can be a lot to squeeze into a visit, even to make the visit longer. It's still a lot of information. And, folks I only have so much energy to stay on my game and talk, and patients have a limited capacity to soak up new information and get enthused about things. So you individualize that, and sometimes I have folks come in for transition visits that are just that, separate from their wellness care. Other times I incorporate it, and that's a decision you make as you go. The age 15 visit, I left the medical things out. Concerns, as I stole from Dr. Cohen, school performance, I wrote trouble making friends in transportation. So how am I approaching this visit? I'm going to explore this visit in a little more detail and talk about process. We think about team-based care. And that's important because it isn't just the physician. And a highly functioning primary care office uses team-based care. There was a time when I was in my training when physicians were expected to do everything everybody on the team could do. So if the nurse wasn't there, I can do the nursing job. If the secretary is there, I can do the secretary's job. That's old school and dumb. It doesn't work, and so everybody works together. There's a lot of overlap, but there's some things that my secretary is simply better at than I am, and our care coordinator is invaluable. So the team talks about the visit. And then the other thing that I think is so important with chronic care management and these transition visits is pre-visit planning. And the way we do this in our office is largely with huddling. Again, I have given a whole talk on this, and I'll give you the short version. After various iterations, what we found is that once a week, my secretary, my nurse, and I get together and look at the week and see what's coming and what may be missing, what we should think about, and just brainstorm about the patients that are coming. And then every evening before the next day, my nurse and secretary get together to look at the nitty-gritty, what needs to be on the chart, how much time the visit might take, what unexpected things might come up. And then also, we put to-do reminders in our electronic medical record, either from the last visit. So, we decided not to talk about sexuality at this visit, but we want to make sure we don't let it go. So next visit, it's on my to-do list, or if there's been an intercurrent conversation with the care manager and we decided to defer something to the next scheduled visit, that we have a to-do list. So that's kind of the process, and it's really important to think about that and do some planning, and not just sort of pick up the ball when the patient walks in the room. Care coordination. These are, again, my two key features. There's lots of features of care coordination. Assigning roles, both in transition and chronic condition care plan, are important. I made a comment here, is what I was thinking. My seventh grade shop teacher taught me measure twice and cut once, so you don't waste a lot of lumber. And I think the medical corollary is check twice and order once. I mean, too often you have both doctors ordering a thyroid test a few weeks apart from each other because nobody's asking if the other one ordered it or not. And periodic laboratory work or other assessments, that should be part of their ongoing care plan. Tracking and administering vaccines, and that came up earlier. Who's going to be in charge of that? And I think the way that's a conversation on the phone or in a letter, and you need to make sure that it's been answered and it's explicit. Who's going to keep track of the vaccines? You need, in this case, because there are very specific vaccine recommendations for sickle cell disease, to not only look it up as the primary care doctor and educate yourself about your patient's special condition, but also talk and make sure you're on the same page and up to speed with what your consultant subspecialist is doing. And then my plan with a patient with sickle cell disease like this would be that I would give the vaccines and we would both track them. Measure twice, cut once. And things are less likely to come into a problem. And then the other part of assigning roles is the symptom control plan or the emergency action plan, which I include in my sort of portable summary care plan. With a fever, who are you going to call? That could go either way, but that's a decision that you make with your subspecialists in sickle cell disease, depending on comfort levels, geography, patient history, and all those things. But the patient should know. This makes patients much more comfortable if they know if Saturday evening X happens, this is the person I'm going to call, and they know that I'm going to call them about this. So these are big features of care coordination. And then the second is information sharing. And we need to follow the Goldilocks principle, not too little, which was what happened pre-EMR. People would show up at the subspecialist office and say, well, what are you here for? You don't know? My doctor didn't send anything? Well, no, and then you've got no information. And vice versa. They'd come back and I'd say, well, how did it go at the hematology visit? They didn't send you any information? I mean, that was pre-EMR. Now, it's how did it go at this visit? And I got a 100-page document that they pushed a send button on. And that's completely useless, too. So another principle is that, in my opinion, the sender is responsible for filtering and organizing. Both sides. There are transition act sheets that the ACGME, American College of Medical Genetics, has developed for many heritable conditions, including sickle cell disease. And this has some good pointers about things to talk about and what's in it. The way you get it, the website for the American College of Medical Genetics is not all that intuitive. So if anybody really cares, you go to acmg.net, and then there's do you agree to comply and be nice, and you click yes. And then there's an act sheet shortcut button in the left lower corner. And once you're in the act sheet section, then you can search it like anything else. You can search, there's transitions, and then you can search sickle cell disease. So I think that's something every primary care doctor should be aware of, is that there are transition act sheets. Behavioral health is important in care of certainly, age 12 and above across the board, but it's especially critical during transitions for folks with chronic conditions. So at the very least, at every one of those visits, you should explore behavioral health with at least a basic screen and some open-ended questions. I have a copy of the screen on the next page, but I use the PHQ-2 as my basic screen and the PHQ-9 as my expanded screen, and I'll show you those in a second. But then you also need those open-ended motivational interviewing type questions where you say, how's it going? Or that must be hard, to try to pull out if they're struggling with fear, anxiety, sadness, conflict, bullying, all those kind of things. So every visit deserves both a screen and some open-ended questions like you were taught in medical school or any other field that you're in. As far as the behavioral and mental health goes, it's real important that this be coordinated with the healthcare specialty team. It's very hard in primary care for many of us in many areas to access mental health services, and honestly, primary care physicians are doing more and more work as the main provider of mental health. But for folks with chronic conditions, there's often a linkage. I mean, you said you were going to now have a psychologist right in your clinic. And so I could be beating myself over the head looking for somebody to see this troubled 15-year-old who's starting to struggle and not find anybody, or if I do, they have no clue about sickle cell disease or chronic condition management in adolescence, and all I need to do is pick up the phone and find out what was going on at the specialty center. We could have really made it happen. So this is the PHQ-2 and the PHQ-9. The PHQ-2, it's not big enough that I can see it. I got to look at my slides from over here. I hate to work around. So 2 is the first 2 questions. How many times in the last 2 weeks have you had little interest in doing things? How many times in the last 2 weeks have you felt down, depressed, or hopeless? And then it's the scale 1 to 4. And there's various grading schemes that talks to you about that, but typically, depending on how sensitive you want to be, a score between 2 and 4 on that PHQ-2 should make you do the 9. And the 9 has some scoring guidelines, and there's some in terms of whether mild to moderately depressed, potentially depressed, and whether to refer or consider medications. But it should take you to the PHQ-9. And then also the PHQ-9 is actually somewhat helpful going forward as a record and a quick score. It doesn't substitute for talking to patients and your impression sitting in the room with them and reading their face and body language, but it is somewhat helpful in tracking their response to interventions for the mental health stuff. So, 15. What do I got? How am I doing? Well, okay. So at 15, I pull out my transition care plan, and start working right down. Have we talked about what sickle cell disease is like? Have we started to think about what vocational aptitudes we've had? Hopefully that's been addressed before, but if not, we need to touch on that. This is definitely a visit to talk about the sexuality issues, and that means, really, everybody at 14, I talk to them about appropriate birth control. And there's some special considerations for sickle cell disease, wanting to avoid any methods that might increase the risk of thrombosis. And that's absolutely something, I don't get into all the details, and preferably in my pre-visit planning, I've gotten a hold of my specialist colleagues to make sure I'm on the right page. And if it sounds like we should be thinking about birth control, we're on the same track. We want something that's effective. And we talk about effectiveness just like you would with anybody else, and talk about what's safe in that given situation. And whether it's time for that or not. I mean, for some 14 and 15-year-olds it is, and you got to kick the parents out of the room for that type of conversation. And sometimes it can be tough to prescribe if it looks like it's needed, but they don't want mom to know. See if they've gotten involved with any support groups. And again, start really talking about the vocational interests. And the other thing I like to do with this visit and throughout is, this is a good time, especially as you're getting into the beginnings of high school, to talk about what's fun. What are your hobbies? What are you good at? Because it puts a positive spin on some of that visit. And being able to spend a few minutes talking about fun things can change the color of the visit and actually motivate people instead of just talking about what they have to do, what they have to deal with. So, 17, insomnia, getting serious with her boyfriend, and expresses a desire to go to college. And mom was not happy with that notion, I recall from the other presentation. You explore the insomnia, that takes you to your PHQ-2, but it also takes you to the reasons that folks this age don't sleep, and sometimes it's because they've got their days and nights mixed up. It's often because the biology of sleep in a 17-year-old is that their internal body clock is a 30-hour clock, and 17-year-olds sleep for 20 hours or sleep for 10 hours and then are awake for 20. I mean, that's just how they are. So, and every teenager does that. They all will stay up until 2 in the morning, and then they'll crash and want to get up at noon the next day. And if there were no lights and clocks, they'd constantly push their clock forward. You talk to them. This is your biology. You got to work against it or live with it. And again, you explore the mental health aspect of the insomnia. The boyfriend thing, a real good discussion then about all the aspects of sexuality, contraception, but also the relationship part of that. And then college is something that I think it's important to, again, talk about their aptitudes and their interests, very much the open-ended shared decision-making kind of planning. What sorts of careers can you picture yourself in? College, you may want to go to college because college sounds fun. You may want to go to college because you really have aspirations, and you ask what their life looks like 5 or 10 years from now. And then you bite the bullet and say, so how are we going to manage your sickle cell disease if you decide to go off to college? And you reassure them that you're going to help them figure that out with a specialist. We're not going to have the whole plan in place, but we're going to figure that out. There are doctors everywhere. There's now telemedicine. Again, I'll jump down to telemedicine. For college students, that's the nuts. Some variations of telemedicine. And that we're going to develop a portable medical summary that you're going to carry with you that has an emergency action plan that you can hand, if you get sick, you can hand to that emergency room physician that says, this is who I am, this is what I have, this is my past history, this is what works best for this condition, and this is the number to call to get a hold of my hematologist and my primary care physician, and that it's not an option to not call. That needs to go on that emergency action plan. And that makes people feel like maybe this is a possibility. And then you kind of share that, bring mom into the room and share that with her. And it's suddenly what seemed like impossible seems like a dare instead of a don't. Age 19, poor compliance, absenteeism for work, desire to move from mother's home. As quick questions that came at the end of yours like it did mine, I think you covered a lot of this. Poor compliance and absenteeism may be cognitive. It may be emotional maturity. It may well be depression. Probably some of it is, or there's interplay with the behavioral health stuff. And that is, at age 19, in my mind, very much a conversation that you should have separately and only with the patient's permission with the parent, but encourage that. So we sit down and have a dialogue about what's going on. Some of it may be denial. I'd be very inclined with this scenario, before I even walk in the room, to be thinking about getting a psychologist involved to help sort out all of that stuff. The desire to move from mother's home is a big deal, too, to the mother and to the patient, and it's probably mixed. A lot of times when you hear very intense statements from teenagers, everybody knows this. It means the more intense they say something, the more conflicted they are about it. So you lay that out there in an open-ended question. It sounds like you really want to do this. I mean, you don't have any concerns, and you can pull that out, and you start the conversation moving. And then you have the conversation that someday you're going to move out, and it goes to the mom too, and you have the same kind of conversation about that you have with the college. I'm going to step back a minute to the 16 and 17-year-old visit, because I forgot to mention this, but if there's issues with cognitive impairment, potentially from the stroke, around that 16 or 17-year visit, you need to start talking about shared decision-making and healthcare proxy, power of attorney, guardianship, where all that falls in, and start to raise those kinds of discussions, partly to know how autonomous the patient's legally going to be when you're done, but more importantly to help the mother and the patient start to define their relationship as they transition from child to adult parent to adult child to adult parent. How does that all play out? I mean, you're still going to turn to your folks, for advice and counsel, but you might say no. And you might disagree with that advice and counsel. And how do two adults give each other advice versus how does a parent direct it? And that's a good, so you talk about it in the legal terms, but you also talk about the way that's going to change. And when mom says, I think you should do this, competent younger child of adult is able to say, I've listened to you, but I respectfully disagree, and I think I'm going to go ahead and do this. And parent needs to learn to accept that stuff. And you have that conversation early on and talk about doing it respectfully. That helps the most important relationship, as you said, which is the one with the parent, not with the doctor, not with the social worker, not with the care manager, but with the parent. It helps it be a healthy relationship going forward. So this is from the primary care end, kind of how I would have managed this case and what I think are the key salient points. I could do 3 hours of lecturing on these advanced primary care and team-based care and transitions and care coordination, but I think I've talked enough for the end of the day.